I want to welcome my next guest because this is where we get some answers for this stuff. Dr. Bridge Bombay of Centric Health. He's a new sponsor of the Richard Bean Show. He comes on every Friday to help us walk through this, to make some sense of it. Dr. Bombay, welcome back to the show, friend. How are you?
Richard, I'm well. How are you?
I'm a little distressed, Dr. Bombay, listening to Ryan Alsop yesterday.
You must live in the same country that everybody else does, so we're all stressed.
We are. I mean, but I wasn't surprised by what Mr. Alsop said yesterday, but there were a part of me, I don't want to hear it, that we're going to have what I heard, my words, not his, a huge spike, an explosion. He said you can expect it. A huge explosion of cases. They're trying to do a lot better job of getting the turnaround on the test done so people don't have to wait 7 to 10 days. I still don't understand that. Does that surprise you that we're expected to see, as the testing really ramps up, we're going to see just a tsunami of new cases?
I think our positivity rate is around 7% in the state of California. So if we increase the testing, yes, there will be a bump, but it shouldn't be a tsunami, because I would expect a tsunami, let's say in Miami-Dade, where the positivity rate is 30%, or Arizona, where it's 24%. So they're severely under-tested. When you have a positivity rate of 7%, there's still a room for improvement in testing, which we definitely have. But I think what he suggests is that there will be an increase in numbers. The tsunami, I suspect, is not really the test-based. Tsunami, I expect, is behavior-based. If we don't alter our behavior, then there is sufficient amount of virus that goes around in the community, and we will continue to have exponential growth of the virus. That's the part that I worry the most about.
Oh, that's interesting. So as time goes on, and if people are lax, then the level of, I don't know what you'd call that, just the amount of virus around it lends to a greater propensity for all of us to get it. Well, Alsop also talked about and I keep hearing this, I wanted to ask you this, that 90%, I've heard this number before, 90% of the people who get COVID come out of it and they're fine. And yet I also hear experts talk about the lingering effects of COVID, a lot of which we're just learning about, potentially neurological issues, lung issues, heart issues, taste. Some people who have fully recovered haven't regained their taste. What can you address that on what science and what experience has shown us, or maybe some of the longer term effects of people who otherwise might be deemed fully recovered?
Richard, we are still learning about the disease. What we're learning is it's a real chameleon. It affects pretty much the entire body: the brain, heart, lungs, kidneys, shock syndrome. In the kids, the multisystem inflammatory syndrome. So it's a very protein or diverse presentation of the disease in multiple organs. As far as the safety profile, in terms of what percentage of the people will have symptoms, asymptomatic, mild, moderate, severe, or recover, I think it's a fair assessment that more than 95% will recover nearly completely.
Okay.
But that has to be somewhat italicized, because when you look at patients who are even asymptomatic and you do CAT scans, there is some lung damage that's seen in asymptomatic patients. Forget about the people with shortness of breath. So what is the long-term consequences of that? It's too early to say that. So you'll only be speculating. The cognitive deterioration some people experience, they call zombie state or spaced out, that's real. The myalgic encephalitis, the lingering, the chronic fatigue syndrome, that's real. The Chronic lung damage, that's the most discerning, but we don't really have a good answer on that. Some people may have clots in the heart causing heart attacks that can have immediate and long-term consequences. Others may have heart muscle involvement, a condition called myocarditis that weakens the heart muscle and puts people in congestive heart failure or worse. So there are a lot of lingering cardiovascular, neurological, pulmonary, even GI side effects or the consequences, which we really don't have a good grasp on, but that's understudy and a source of much consternation.
I mean, can you explain to me in a medical sense of why is, I mean, it's just bizarre to me that some people, you can be in your 90s and contract the virus and recover, and you can be 18 and die. Some people have lingering effects, some don't. Is there any common denominator you can put your finger on other than pre-existing conditions, or are there some pre-existing conditions to have that make it worse to have COVID than others? Why is it so I mean, why is it that everybody seems to be suffer this disease this virus in a different way?
The COVID is a very heterogeneous disease. Its heterogeneity is different even in different parts of the world and even in the same part of the world in different sections of the population. So it's from that perspective, it's an amazingly diverse disease. The aging has a very significant component to it because two things happen when we age. Our tendency for inflammation goes up and our immune system goes down. And those are two variables that are very important in the fight for this virus. Because early on, when you have a viral infection, you need immunity to deal with the viral spread. Then the inflammatory part takes over. The infection part is early on, that's countered by immunity. The virus may go away from the system, but it'll initiate an inflammatory response that may go out of proportion and pretty much damage and kill the person. So when you have lesser immunity as an older person and higher tendency for inflammation, that's a stage set for a worse outcome. So age itself has its own challenges.
Yeah.
Diabetes, similarly, is an inflammatory thing. Atherosclerosis, similarly. So all the pre-existing conditions when we talk about, what's common in them is, one, somewhat compromised immunity, two, somewhat increased inflammatory proclivity. So with the combination of the two is what lends to a worse outcome.
What is it? You know, that this the inflammation has gotten a lot of attention in the last few years, and then certain conditions, arthritis, Crohn's disease, psoriasis, those type of things are being treated with biologics, which trick the immune system into because what you have is immune disorder that's overreacting. What is it about this our immune systems that have gotten out of whack, or is this a case of science just catching up with reality and giving it a name?
The name is called cytokine storm. It essentially is that the natural inhibition to counter an infection is exceeded by an outburst of inflammatory response that becomes self-destructive. The reasons for that, the cytokine storm, are not well understood. But what's happening, Richard, is that we are developing a number of pharmaceuticals recognizing that inflammatory response begins fairly early on. And if you can suppress that inflammatory response, we can contour that inflammatory response in a way that's constructive and not destructive, we can minimize the catastrophic outcomes of COVID. So there are a number of pharmaceutical, and my money is on pharmaceuticals, that we will have an excellent set of pharmaceuticals that will be able to modulate the inflammatory response in a non-destructive manner to minimize all the consequences short-term and long-term from COVID. In that context, we talked about the steroids or dexamethasone in the past. There is a medicine called colchicine. It's a medicine that's commonly used for gout. We are in Bakersfield, in collaboration with the Montreal Heart Institute and NYU, initiating a trial in which we will be providing colchicine to people who are 40-year-old or 40-year-old and have at least one other comorbidity or pre-existing condition that lends them to higher probability of bad outcomes. So this study is funded by Gates Foundation and others. Well, it's a double-blind, placebo-controlled, randomized controlled trial. So what we're trying to do, Richard, is to take care of this inflammatory storm on an outpatient basis that will minimize the inpatient trend, decompress the hospital occupancy, and the ICU utilization. So between steroids, colchicine, and a number of other anti-inflammatory and another set of medications which you alluded to is called immune modulators. And then similar to dialysis, there is a system called CytoSorb, which basically means you absorb the cytokines through the dialysis-like device. We should be able to fight this disease mostly on outpatient basis. If you're successful in that, and then you throw in the vaccination and the continued expansion of the herd immunity, we can begin to see an outline of the world that we used to live in, I would say, 8 months from now.
That's some good news. What if you're somebody who suffers from psoriatic arthritis, and you're on a biologic, you're on Humira, or just pick one of them, and you're using that to treat your arthritis, and you contract COVID, does that put you at particular risk when you're already on a biologic because of the inflammatory response?
Yes, because remember there are two stages. The first stage is where you need the immunity to minimize the viral load. The second stage is where the inflammatory response goes in hyperdrive and then self-destructive side. So when a person is already immunocompromised and is using immune modulators or the immunosuppressors, they're immunocompromised. So they're unable to deal with the virus to minimize the viral load. So they're exposed, those persons are exposed to worse outcomes, generally speaking.
Oh, man, and there's a lot of people on those now, Have you heard anything? We're talking to Dr. Bridge Bombay of Centric Health. Dr. Bombay, have you heard anything? I just read a little thing today. It's about the third piece I've read on it. There's some early research that researchers are looking into whether cannabis or cannabis-derived CBD may offer some benefits from folks suffering from the infection. And they talk about that its ability to reduce, they call it ACE2 expression and pro-inflammatory, that cytokines that you just mentioned. Do you know anything about that?
Actually, I don't, and that means it ain't, because I'm just exaggerating that a little bit, because there are a lot of alternative medicine folks, and that would include the people who want to cure everything with the plasma, with the stem cell, with the cannabinoids, and other things. But there is no mainstream research body that will help support those claims.
Okay, so if you're not aware of it, when you say 8 months, so it doesn't sound like a vaccine alone is going to be enough, does it? it's going to have to be a combination of both treating people who already have it with one thing and then a vaccine. And how effective are vaccines? I mean, vaccines have never been 100% effective, are they?
So that's a very good question, because I think at the end of the day, we're going to deal with it. We may never be able to defeat it. We will be able to deal with it with a trifecta approach. Of course, that assumes the preventative things that we already talked about, the three C's, avoiding the congested spaces, close contacts, and crowds, especially in the setting of loud voices, prolonged contact, and stuff like that. So that assumes that. Let's take that out of or keep that in the equation. But the other three things that will help are: one, controlling the spread in a way that it doesn't become a conflagration and creates the supply-demand disequilibrium. Two, we have the pharmaceuticals. Three, we have the vaccine. The point you raise about the efficacy of vaccine is actually true for everything we do in medicine. There is nothing 100%. Okay. So typically speaking, a vaccine is 10 to 15% non-effective. In the case of flu, it's only effective in 50% of the people. So what we're trying to do with the vaccine development in the case of COVID is we have essentially 100 or more Manhattan projects going all over the world. The scientific community has decided to put everything else on the hold and put all their energies in developing the vaccine. Yes, a successful vaccine against the coronaviruses has never been developed, but the existing platforms have been repurposed. All the research has been repurposed into developing a vaccine. That doesn't guarantee its success, but that increases the odds with certain caveats. One of the caveats is that when you are pursuing such a large project on an accelerated timeline, would people interpret the vaccine in a political light? Then is an accelerated timeline somehow going to compromise the safety? And we have a huge contingency of anti-vacciners on both left and right. There is a trust deficit. And then what happens is if a vaccine has any side effects, they will be sensationalized, especially on the social media, where the data doesn't have to exist. Disinformation can be invented and assimilated by large sections of the populations. So my concern is, I think we'll have effective vaccine. It may not be durable. It may not be completely effective. At least it'll be partial and land us 6 to 8 months at a time. So it may need 2 or 3 shots to achieve even that partial immunity. But 1 or 2 or 20 different vaccines will exist. But the existence of vaccine is not binary. Once you have the vaccine or vaccines, you have to cover those logistical challenges of making sure the vaccine is available to all the people, it's in large quantities, and how it's to be staggered between the high-risk population, let's say healthcare providers and elderly, and how it walks down through the society. But my concern, over and above everything, is the trust deficit. My concern is that even if we have, let's say, 8 or 10 good vaccines,
Hello? Chair?
Got a weird hum out of that. I don't know what happened.
Did we lose him?
No, I think he might be there.
Dr. Bombi?
No, I think he's gone.
He's gone? Looks like we lost Dr. Bombi. That was a great point he was making there. I was hanging on every word. Look, if he calls back, thank him. We'll have to get him last week. We're running out of time. Get him next week. It's 2:26. Let's take a quick break and be right back here on KERN.